Good evening and welcome to this meeting of the Healthier Communities and Older People Overview and Scrutiny panel. Item 1 is apologies for absence. Do we have any apologies? Thank you. Right, but both recorded. Thank you for substituting again, John. Item 2 is declarations of pecuniary interest. Are there any declarations? Okay, duly noted. Any others? Item 3 is the minutes of the previous meeting. Are they agreed? Not agreed.
On the minutes, just a small point on the discussion that we had about COVID last time, and we talked about the numbers of deaths in people's homes, and I think that's also featuring on the agenda later, but it would be good to record that was discussed in the February meeting. So it's page 1. All
right.
Item 4, impact of COVID in Merton.
Yep.
So just to amend it to reflect that discussion happened. And also
what exactly are you asking to insert? Or
well, so basically agenda item 4, there's a kind of recap of the discussion that happened, but it omits that point. So, a panel member raised the number of deaths in homes and whether this was unusually high, and it was agreed to look into that.
You got all that? Stella? Yeah. Okay.
Great. And then the other point I wanted to raise, and I know there's been a bit of email communication about this, was around the update that we've been due on cancer screening for some time. And I'd raised that again on agenda item 7, the work plan, which it isn't minuted, that I'd raised that. And I understand that the NHS has been in touch to say that they can't provide that update until the next municipal year. And I'm quite concerned about this. Everybody appreciates the pressures that the NHS has been under. We all understand that in this committee, most of all, but we have had a number of updates from the NHS over the past year on non-COVID related topics. We had one on the new reorganisation that they're doing. We had one on the diagnostic services. We've had several others. And this is information that is publicly available online around cancer screening. And I had a look at Merton, well, not Merton, but the South West London CCG rates, and they are showing a disturbing trend. I've got some handouts which I will pass around to panel members. But just to give you one example, if we look at breast cancer screening for people who are aged 50 to 70, we've dropped to 10 points below the national average. And that is just looking at us as a South West London CCG area. If we were to look at Merton within that, we may well be even lower, because we know that typically we can fall under the trend. So I'm just quite concerned because, as I said, we all understand the pressures that the NHS are under, but they have found the time to update us on other things at the CCG. And this is, a data set which already exists. It's a matter of somebody from the CCG, coming to our committee and us scrutinising whether we are really falling quite seriously behind, which the data suggests we are, whether it's breast cancer, cervical cancer, bowel cancer. It's a worrying trend. So I will distribute this among panel members. It took me about 5 minutes to find this online. But I just, I'm putting it really to the committee that I think we need to see more urgency with this item in the future. I asked for it a year ago to be on the agenda. Thanks, Chair.
Chair, can I just clarify, it's NHS England, not the CCG?
From my perspective, we are not a Senate committee with the power to subpoena people to appear before us. We issue invitations to officers of other agencies, but they don't work for us. And if they write back to the clerk to our committee and say that they are under pressure, there is no way that I can compel them, and we have to kind of ask them, when can you give us this information? And they've given us an indication that they can attend in June. It's regrettable that they haven't been able to do it. I don't know the circumstances of those individual officers and what other responsibilities they have, but what I have been assured by Stella is that they have explained to us that they do not have the time and they've been under pressure as a result of the pandemic. And what else can we do? I cannot drag them in here and ask them and demand that they give us information without their support and cooperation. It's as simple as that. We do not have the power to do that. And I think we have to recognise the limitations of what we can and can't do. And we have to recognise that, officers that work for other organisations may see our priorities in a different light to the priorities of the organisations that employ them.
Chair, can I just say, just clarify to the panel, I've been liaising with NHS England and they have attended this panel over all the time that I've worked in this organisation, over 10 years, and they have always been willing to come along and to present this information. It's simply because of the pressures of the pandemic that have meant that they've asked to delay it from what month are we in, March till June. Simply because of that reason, they have been very willing and very cooperative at all times. Chair, initially that was for the other set of that was for immunizations. I discussed with them when would be the best time for them to bring this information because of the pressures of the pandemic. So I approached them to say, when can we put you into the work program? And then they said the best time for us is February. And then you asked me to go back and to ask them to come in January, which was 4 weeks earlier, which was a bit, because they'd already made plans. They had somebody on secondment and they'd made plans to come in February. So there's a 4 weeks discrepancy, Chair. And they did bring that report in February.
Thank you, Chair. I mean, Mike, and that would all, I think, be perfectly valid were it a huge piece of work, but this is stuff that's online and easily accessible. So I just think that, we all understand the pressures.
The issue is that it's not a question of just here's the information. We're asking officers of NHS England to come and present a report. And I don't know about you, but when I present, I prepare. And if that involves time and they have conflicting priorities, then I guess they have to discuss them internally within the organisation. Are you asking me to make a formal complaint on behalf of this?
I'm just asking that we put on record that this is a really urgent item. If you look at the trends, the trends are disturbing, and everybody appreciates the pressures, but it will have been 2 years since this committee heard about cancer screening rates. And if people are not being screened, cancer will be missed, and that will store up problems. So I will pass this round so members can have a look at the rates for themselves. But I just wanted to place on record that I'm disappointed it's taken so long.
In that case, if you are disappointed with officials from NHS, why don't you make a formal complaint to NHS England?
I don't think it's in my remit to do that. It's for the committee to discuss and the committee to decide, but I will circulate the information.
Okay. Anyone else want to contribute to this? Okay. So we're now going to go on to the substantive item, having received the initial or listened to or viewed the video that's been provided. Is Dagmar around? Yes, you are.
Yes,
hello,
hello, I am.
I couldn't see you earlier. Welcome. And would you like to introduce this report?
Yes,
I
please,
can
Chair,
see you're
if you
going to be
allow
very
me to.
busy tonight.
So good evening, committee members, those in the room as well as remotely. Can you hear me? Yep. So the remit of the report was to look at impact of COVID on care homes in Merton. And we've concentrated and asked the committee particularly to consider obviously the challenges, but also the multi-agency response that we are, I think, rightly quite proud of. Very importantly, the lessons learned, because obviously it was a very tough time for everybody. So what does that mean for living with COVID and the eventuality that we have to stand up again? And then we do ask as well to take this as an opportunity to particularly thank all the frontline staff. I think you've seen the paper with the details. There's the appendix as well that goes into details about some of the underpinning data. I've got colleagues here, Mark Krellman and Annette Bunker from the CCG, so thank you very much, as well as Keith Burns from Adult Social Care. So pulling this paper together was a real joint collaborative endeavour. And Chair, over to you and committee members to ask any questions.
Thank you, Dagmar. Do any of your colleagues want to say anything by way of introduction, or are you happy to just go straight to questions? Mark.
Chair, Mark would like to speak.
Yes, please go ahead, Mark.
Sorry, apologies. I'm used to Teams, so trying to find my hand and get off mute was quite complicated. Just to emphasise, I think really the partnership approach, and actually across the council, across South West London CCG and the Merton team, and also CLCH, our providers, really was a kind of a team approach here. And with the speed with which the response was kind of initiated, I think deserves everyone's kind of like gratitude, really, but also to remember that the GPs play a role not just in the care of the residents, but also in the vaccination program there. And I think the video that we saw earlier probably just highlighted that. So yeah, I just wanted to emphasize and support Dagmar's narrative.
Keith, do you want to add anything before we start questions?
Chair, I don't think there's anything I need to add at this stage. I think Dagmar and Mark have summarised very well.
Great. Are there any questions? Helena.
Thank you, Dagmar, and everyone in the team who helped compile this report, and of course, you know, all those who've worked throughout the pandemic on these issues. One thing I wanted to ask, I'd heard that the Department of Health had actually praised Merton's response in terms of its handling and its work with care homes, and kind of drawn it out as an example of best practice across the country. I just wondered if you could perhaps tell panel members a bit more about that, if that's the case, because I think it's an excellent example of everybody working together. And also on the paragraph 3.20, which is on page 11 or page 7, depending on which one you're looking at, the temporary alternative discharge destination facilities, you know, looking at what happened to people who were discharged from a hospital before they went into a care home. You talked about the facilities that were set up, those kind of midway places where people could go. And the first one was set up in November 2020. And I just wondered, they're called TAD facilities. I just wondered, you know, was that something that you had to wait some time to get funding from central government? It took a while to set up. And are there plans in place in future if we were to have anything similar to kind of quickly get that up and running again, so that we don't see the problems we saw in the early days of the pandemic?
Thank you. Who's going to answer that? Dagmar?
Okay, if I start, I'm delighted that you heard the praise. I'm passing over to Keith in a minute to fill us in a bit. I think it very much refers when the minister came around and looked at all our plans, and we early on really demonstrated, particularly what you heard with the staff, that we actually had really close relationships with every single care home, and we phoned them up, and I think that was the particular reason for praise from the minister at the time. But colleagues, have you got anything else to chip in, Keith or Mark?
So, Chair, I'm happy to come in. So I think Dagmar's right. I think one of the things that I think has been incredibly important in the way that we've responded, but also in the way that other agencies like Department of Health have viewed the Merton response, is that we've completely changed our relationship with the care homes in the borough that we perhaps didn't have a particularly strong relationship with before the pandemic. Members may well be aware that when we're buying care home beds, there are only a limited number of care homes that we're able to buy beds from at prices the council can afford to pay. So prior to COVID, we had a relatively limited relationship with those care homes that we weren't purchasing from. That relationship, I think, has been transformed over the last couple of years. And in fact, a couple of the care homes that were featured in the video are those care homes that we wouldn't ordinarily be buying beds from for people that we were placing, but that we now have a very strong relationship with. And I think that's one of the hallmarks of our response locally. And that's one that I think has been kind of praised at South West London level and more broadly. I'm going to hand over to Mark in case Mark wants to pick up anything on that point, and then I'm happy to talk about the TAD beds, the temporary alternative discharge destinations.
Well, actually, Keith, I was going to talk about TAD, so why don't you do TADs first and I'll just chip in there.
Okay, let's see if we agree, Mark. So, Chair, on TADs, temporary alternative discharge destinations, these were, I'm trying to remember which, so I think this was wave 2 of the pandemic, and there was a recognition, I think, that one of the early lessons from the initial stages of the pandemic in March, April, May 2020 was that we needed to put additional safeguards in place to make sure that people who were ready to leave hospital but who were still COVID positive were able to be discharged safely. And that meant, and that was a national policy change. So that meant a need to identify care homes where facilities could be created that would enable the care home to care for COVID positive residents safely and in a way that didn't risk the other residents of the care home. Now, I think that was a policy announcement that was welcomed, but it was also one that was quite difficult to put into practice because it's actually quite difficult to find care homes with the right number of vacant beds in the right configuration. It just so happened that one of the care homes in Merton was in that position. They'd just finished refurbishing a wing or an area of the care home, and all of the beds in that area were vacant. So we were able to actually move quite quickly and work with our CCG colleagues to secure those beds as the first of the temporary alternative discharge destinations for South West London. And that setting operated for a number of months as a TAD, and during that period a second home was also set up as a TAD, and that was in Sutton, although in Sutton but supported by a Merton GP practice. And once the initial pressure had worked through from that second wave, there was a reduced need for TAD beds overall. And so the Merton setting was closed down as a TAD facility. The Sutton home remained and remains, I think, until the end of this month as a TAD facility. If we needed, if there was a need in the future to do something similar, we would of course be ready to do that, but it is very dependent on being able to identify a suitable facility at that point in time, and that I think would be something that we would just have to tackle as and when we needed to tackle it. Thank you, Chair.
Mark, do you want to add to that?
I just wanted to say that I wouldn't underestimate the kind of the impact TADS had, because it was an alternative to kind of people going back to their care homes. And actually congratulate, it had nothing to do with me, congratulate our kind of local authority colleagues and our GPs, because although there was a site there was still quite a lot to think through around IPC, around the clinical model, what was the support that was needed in this completely new environment. So I just think Merton certainly, and I know from other boroughs, Merton embraced it and went with it, and it was quite groundbreaking. You know, that led to another one coming on track. And even in the last wave, we saw that TADs were still needed to help release some of the pressures in hospitals. So I think it was fortuitous about the home, but I do think Merton embraced it in a way that kind of really made it work. So again, it's congratulations to those that were involved in it.
Thank you. Can you both put your hands down if you don't wish to speak again on this item, Mark and
There you go.
Keith?
And apologies, my camera's gone.
Oh, Dagmar, do you want to speak on this specific question? Can't hear you.
Sorry. No, I'm good. I think my colleagues have outlined the main points.
Janice, you've got a question.
Yes, I'd like to echo Helena's congratulations and thanks. I think we can rightly be proud of Merton and our care homes and everyone that made it the success it was through the pandemic. My question is, I'm sure there's another variant coming down the tracks maybe by September that will take us by surprise. Are you continually refining your plans for the September onslaught that may be coming at us?
Shall I take that? And I can also then introduce possibly Dr. Anita Davis, who has actually been leading the infection prevention control team. So Janice, I think it's a really good point. What we're doing at the moment is, as you are aware, we're in the following the national guidance, living safely with COVID. And at the moment, we're in what we call transition. So we have to wind down commensurate with the infection risk at the moment, reducing, and the harm from infections reducing, but very much in keeping our capabilities and leaving a legacy in case we have to stand up again. And so what we are fortuitous in Merton is that our funding for our infection prevention control team, we've managed to keep a little bit for rainy days, and we are allowed to roll it over. So we won't have to stand them all down by the end of March, like a number of other areas have to, because the money is only until the end of March and plus rollover. So we are tapering, and we are very much working, and you've heard it from our care home managers as well, to really train the trainers and keep some legacy in the system in terms of skills, toolboxes, etc. That's the sort of overarching preparedness. But if you allow me, shall I invite Anita as well to speak?
Anita, do you have anything to add to Dagmar's comments?
Thank you, Chair. We'd just like to add that the care homes have a designated person, they have a named person, and that made things helpful when they did not understand the ever-changing guidance that was mentioned in the video, and we still continue to be the intelligence on the ground, so we constantly keep in touch with them, we know what's happening, and that matches with our public health intelligence, and once we see any change, we're in there physically and giving the support that they need. Thank you.
Thank you. Are there any other questions? Nigel.
Thank you, Chair. first thing I would like to say well done to the care home, throughout the period, the co-worker and the impact on the staff and the lesson learned for the future. As we all agree, we're not fully out of work. The closure of it is now a purge. We have to probably learn to live with it and be cautious. And I understand that the government is now looking into having for jobs for the people over 50 years old, which is great. But and there is a question on page 8, section 3.7. Is it possible? Can you explain more about the comprehensive resource for care home that was developed by a mutual discipline care home support group? Thank you.
Dagmar, are you going to deal with that one?
Yeah. So thank you, thank you, Nigel, and thank you to actually thanking the staff. Really appreciate it. So with regards, first of all, yes, confirmation that vaccination is our big tool, and so the spring booster. Very much we're working with care homes because residents and staff in the right groups are absolutely included in that spring booster, and we are fully anticipating and preparing that vaccination will stay on the agenda. So I was in a way happy to hear as well how individual managers, you heard one of them from Q House, actually through her personal endeavors managed to bring her staff with her in terms of vaccination. So that absolutely is one of our big ways of protection. With regards to the paragraph 3.7, the comprehensive resource pack, it was something we worked at London level from the first wave onwards, because the importance of COVID in care homes was obviously only one thing about many other things that the carers and health workers in care homes are doing for their residents. And as you've heard again in the video before, people in care homes normally have lots of morbidity. So they have lots of illnesses, they have dementia. And so in order to provide good quality care, the care home staff and the visiting health staff have to integrate looking after COVID into many other things. And particularly one thing that I think Helena has mentioned before, as well as end-of-life care. So a number of residents are in that stage and will get support. So we were therefore really keen for to support the care home staff more holistically. And the resource pack is actually really impressive in how quickly the right people came together and pulled together in a very accessible way the main sort of quality initiative in care homes to make sure COVID is part and parcel of it, and not lose the importance of other quality issues amongst the focus on COVID. That's why we put it there. It was a really good pan-London endeavour, and our care home managers, as well as our GPs, actually really loved that resource pack.
Thank you, Dagmar. Jennifer.
4.5.5, the impact on care home staff. I'm obviously very grateful for the commitment and the challenging times that the staff had. So looking at the staffing vacancy rates now, is there a concern at all with those rates? Obviously, during that time, you were using agency staff. I wonder if that's still continuing. So what are the pressures? Have they been resolved now? Thank you.
May I pass that on to Keith? Is that all right?
Thank you.
How do you feel about that, Keith?
Yeah, so thank you, Chair. I mean, I think so there were quite significant pressures on workforce and on vacancy levels over the course of the pandemic. That has been reducing somewhat, and I think I mean, inevitably there was quite a bit of worry about what would happen as we approached the November date last year when the vaccine mandate came into effect for care homes. In the event, we did a huge amount of work in advance of that, and actually we saw relatively small numbers of care home staff leaving as a result of the mandate, particularly. What we can't yet fully know is what the impact now of the decision to revoke the mandate will have in terms of care homes being able to recruit more staff, and we also need to kind of temper that against the recognition that, as Dagmar will rightly point out, the vaccination remains an incredibly important part of our tool in terms of our toolkit in terms of keeping care home residents safe. So I think that the revoking of the mandate means that it becomes easier in some senses for care homes to recruit staff, but we also need to recognise that brings its own risks in terms of potentially recruiting staff who are not vaccinated. We are working closely with our adult learning colleagues to try and look at ways in which we can take some of the really good training and professional courses that happen at the college and at different colleges in and around Merton, and look at ways of streaming people directly from those courses into careers in the care sector when they leave their courses. And we're looking at that both in terms of our own in-house provision, but more importantly, I think in the context of this evening's conversation, in terms of how we can support those routes from those training courses into care home sector across Merton.
And Mary.
Anyway. Oh, thank you. My question to the panel about nursing homes is about nursing staff and the care workers. It was reported that they were quite reluctant to take or get the vaccination, and then some were doubly vaccinated but refused to take the booster. Can you update us on the position as it is today? Thank you.
Shall I start? Or Keith, you have, I think, probably got the latest up your sleeve. Is that okay?
Yeah, thanks, Chair. I can take
Keith,
that.
do you have the latest data on the vaccination of staff? Sorry.
I do. So if you just bear with me 1 second, I will get those figures up. So in terms of vaccine uptake as of today. There are 1,008 directly employed staff in care homes across the borough. 976 of those 1,008 are double vaccinated, so there are 32 who are unvaccinated, and those 32, almost all of those have an exemption of one kind or another. So there was an exemption for staff who'd been vaccinated abroad. There was an exemption for staff who had a medical reason not to be vaccinated. And there are 93 agency staff as of today working in our care homes across Merton, and all 93 of them have had both doses of the vaccine. In terms of boosters, the figure isn't as good. So we know that as of today, of those 1,008 directly employed staff, 540 have had the booster. So that's just over 50%. And only 24%, 23 agency staff have had the booster. So the numbers for the boosters are much lower, but I would contextualize those in terms of the position across Southwest London and across London and nationally. And actually, although those figures aren't great, they are very good in comparison with the figures for other parts of London and England, in fact.
Thank you. Joan.
Thank you, Chair. I'm reading into page 15, paragraph 5.7. And it's, I just want to get a little more knowledge about what's written here. Is it saying that since the pandemic, the private care home, the council have been supporting them more? Is it in the act or in financial support?
So, Chair, I'm happy to pick that up. So I think it's a good question, and it's a mixture of support, really. So I think, as I said in response to an earlier question, I think one of the really important outcomes, if you like, over the last 2 years is that we strengthened our relationship with a lot of those care homes. Prior to the pandemic, we didn't have a huge amount of reason to be having regular conversations with those care homes that weren't accepting publicly funded residents. We now have those conversations on a much more regular basis, and we have those, we have conversations that involve all 38 care homes. We don't talk just to the ones who take publicly funded residents. So a lot of it has been about support. A lot of it has been about communication, conversations. But again, one of the things that we should be really proud of in Merton is that from very early in the kind of first phase of the pandemic, so from March onwards, from March 2020 onwards, we, I think, recognised that there was going to be real issues about PPE availability, and we moved very quickly with our corporate colleagues and with CCG colleagues to find sources of PPE. And in fact, we distributed, I think it says somewhere in the report, we distributed over 1 million items of PPE that the council had purchased to care homes across the borough at no cost to those care homes. And we didn't distinguish between care homes who accepted publicly funded residents and those who hadn't previously accepted publicly funded residents, because the pandemic was all encompassing and we needed to respond equally to all care homes. There have been various other forms of financial support that have been provided, and those essentially have come from government and passed through the council and on to care providers, both care homes and home care providers and other social care providers. And again, the national guidance around those funding streams was that they needed to be passed on to all care homes, to all care settings. So we followed that guidance and passed that funding on in an equal fashion to all care homes in the borough.
Thank you. So I think I'm looking at the recommendations on page 5. I think we have already done A and B, and I'd like to ask the panel to agree C, specifically that the panel offer their formal thanks to all staff working on the front line in care homes who have worked incredibly hard in challenging circumstances throughout the pandemic. Can we agree that recommendation? And the others I think we've already done. So Dagmar, could you arrange for a letter to go to all care homes explaining to their staff how grateful this panel is on behalf of the citizens of the borough?
I'm delighted. Thank you very much, Chair. I will do that.
Okay, so if we can now move on to the item 5, which is an update on COVID rates in Merton. And this is Dagmar again. Your productivity is going to be incredibly high by the end of the evening, Dagmar, but if you'd like to introduce this report, please.
I will. So, Chair, if you allow me, that I will give you an overview, and we use the slides as a reference rather than me going through every and each slide.
Please, thank you.
So, in summary, the infection rates in Merton have been going down. Similarly, outbreaks have been reducing, and the impact on hospitalization had been steadily going down. I say with a little but, because very recently, and you probably have picked it up in the national and London media as well, there's a bit of a plateau. We seem to be stuck a little bit around 6,000 cases thereabouts in London. What is quite important to understand is that what's the impact? Remember, we not just look at infection rates, but as impact. So our hospitals indeed have seen also a slight uptick, but it is still very much patients coming into hospital with COVID rather than because of COVID, because the infection prevention control arrangement in hospitals still very strict. So everybody who goes there gets tested. And so a number of people will be identified as having COVID who come to hospital with something else. So our intensive care units, for example, the ventilators, there's no upsurge. But you will have heard in the press, particularly in Scotland, I think the phenomenon in Scotland is probably the strongest in terms of a slight uptick. Is due to the BA2 variant of Omicron. So remember, Omicron has been a variant of concern. The original Omicron is called BA1. It's just a name. And Omicron has continued to mutate. That is normal. And our genetic laboratories monitor that very closely. So there is one of the mutations, it's called BA2. And BA2 is even more transmissible than BA1. And that is assumed to be one reason why we have a little bit of an uptick. There is no evidence that BA2 has any different ability to escape either immunity or cause more harm. And as you're aware, it's not designated as a new additional variant of concern, but as an explanation, that is a reason most often cited. And so we keep an eye. But what is very important is that the sort of plateau is no reason for us not to continue at the moment with a national plan to live safely with COVID. And that has two parts. One is what I call the transition. It's basically winding down our acute COVID response, but preparing and holding on to the legacy. And then the second part is that we keep the preparedness for eventual potential surges. And as Janice already said, we're obviously all particularly thinking about autumn and winter coming a bit later. So just as a reminder about the transition, because it is important for the committee to understand, so testing from 1st of April, there will be no more universally available lateral flow test or PCR tests. That is very important because living with COVID, the sort of destination of what that means is living with COVID as with any other respiratory illness, and the best example is flu. And if you think about it, if we have flu, we're not rushing out to test. Yeah, so that is the how we imagine how we live with COVID. So no more universal testing. Obviously, testing if somebody is seriously ill in hospital, they will have tests, and people who are particularly vulnerable will also still have access to tests, so that they have also access to the antivirals. That's one really important change, which also means that I won't have any more of my shiny data. So this will be your last regular situational update report, because without the tests, I haven't got all the rates. Now, it doesn't mean that we are now driving blind. We will rely a lot more on the survey data. There are big national surveys that sample people for immunity, and they sample people for the virus. And we then have to apply those national estimates to local situations. Obviously, if we are spotting, for example, lots of people with respiratory symptoms in a school, or even only a few people with respiratory symptoms in a care home, we have a very low threshold to test. In fact, in care homes, we're expecting that regular testing continues. We haven't got it all, the details, but care homes is one of the settings where we expect ongoing testing. So testing is going, the surveillance report is going. Contact tracing has already ceased on the 24th of February. The national contact tracing system was wound down. Our local contact tracers have stopped because there's no more self-isolation mandate. We're using some of the staff until their contracts finish at the end of the month, very creatively, for example, helping schools to identify and find some of the missing children, because they have got those skills. The other bit is IPC, you've already heard. There we are very fortunate, because we, I think, managed it prudently. We're not having a cliff edge, and cease with all our IPC by the end of March, because the pandemic will not have finished, as Anita stated, and her team will ready to first of all create real legacy, but also are still absolutely on standby to ease out of the current response. And then finally, vaccination. That is our big plank, together with therapeutics, and we are working very much behind the scene, particularly on staff and our vaccination equity plan, to ensure that those who haven't got vaccinated yet, that we still very much have a tailored approach to get as many as possible vaccinated, and the spring booster and the children's offer as well. So that is a very brief canter what it means living with COVID. In the slide set also, if you allow me very briefly to mention, because it had been raised in a previous meeting, there was the question about people hospitalized in Southwest London, how many are vaccinated, how many are unvaccinated. We've worked very closely with our NHS colleagues on this, and it's very important to be clear that direct Merton resident data who are admitted to hospital in a Southwest London hospital, whether they are vaccinated or not, I haven't got that data. But we have got very reliable and good quality national data. I've pulled you together one slide, and not surprisingly, so hospitalization rates are much higher in the unvaccinated than the vaccinated, and generally hospitalizations are much more common in older people. You find that on slide, I think, number 12. And then finally, and I think, Elena, you mentioned this before, there had been, I think twice, it was raised that the committee wanted a little bit more granular data on place of death. Our SAR, every time we present the SAR, we show you COVID death, non-COVID death, and the comparative death in the similar week in 2019. So you can see in the different waves that COVID and non-COVID death all raised, obviously. You also see that we then dipped and we had less death at some weeks and months than in the comparative time period in 2019. And so we took the data and looked at place of death, and we looked at for all-cause mortality as well as for COVID mortality. And the sort of key messages are that COVID patients died more in hospital than non-COVID patients. It is not surprisingly, because respiratory distress to be managed outside hospital is a difficult task. It can be done, but it is more difficult. And that generally Merton, in comparison to Southwest London, to our other boroughs, are pretty much middle of the pack. So there is nothing sticking out. And again, I mentioned end of life care in our care homes as well. It's obviously very much, if one can plan, that it is very much planned with the preferred place of death, rather than having us outsiders judge whether hospital or home is the preferred or better way. That very much is, if you have time, you plan it with a family. And often in the case of COVID, it was more an emergency. And so the death in hospital were more emergencies. So I think that's the nutshell of the report.
Thank you, Dagmar. I think there may be something of a public health risk to councillors in this room this evening. You're not with us, so you don't realise just how cold it is in here. But I think there may be a need to alert the NHS to receiving a number of us fairly soon after this meeting ends, because we'll be suffering from hypothermia. I'm not quite sure what's gone wrong, but is it the air conditioning? Is it all the windows open? But whatever it is, I can see people all with their coats on, really. Oh no, apart from Helena, who's kind of superwoman, and Nigel, but everyone else appears to be suffering. So if you could have a quiet word with whoever is responsible for the heating in here, because it would be a terrible shame if somebody whose name was already on the ballot paper were to drop dead as a result of spending time in the council chamber. Right, are there any questions to Dagmar on this particular item? Okay, well, I take it that you have given us such a clear and thorough explanation, Dagmar, that you've done the job. I just wanted to kind of check with you. You referred to hospitalisation rates following, relating to vaccination, and it was on slide 12. I'm looking at it and I'm kind of trying to work out, am I right in thinking that it's between you're 3 times or 4 times more likely to end up in hospital if you haven't been vaccinated? Is that, I'm just looking at it without a slide rule or a calculator to hand, just looking at the bar charts.
Yeah, so what we need to be aware of, it is a very crude measure. So it's not particularly granular because it looks at all hospitalizations and a vaccination status. But that's the gist, that you're just a lot more at risk of hospitalization if you're not vaccinated. And I think that was the question, because what we're using that message as well when we're promoting vaccination. Yeah, so if people say, actually, I think I'm okay that we then can say the facts. They are obviously averaged out, and the individual might not fall into that average. But on average, when we look at our hospitalization rates, then it is a very stark difference that the unvaccinated are absolutely overrepresented. And that is obviously a concern. And people respond to that because it's not some made up fact. It is what we see day in, day out. And that's obviously, my NHS colleagues are on the call, but if we speak to our particular acute colleagues, that's what their observations are. And I wanted to just double check the national data, that those observations are tally with the actual national data, and they very much do.
So the simple message is get vaccinated. It remains get vaccinated.
Yeah.
And it is important for everyone to understand that very simple message. Okay, right. Joan, I've given people the opportunity to ask questions, and we're finished now. So is this, okay, thank you. Item 6 is the report of the Health and Wellbeing Board, and Dagmar, you're going to present that as well.
I'm so sorry, you must get a bit sick of my voice. So I try to make it brief because you've obviously got the report. So just a reminder what the purpose is. The Health and the Scrutiny Committee, so your committee, on an annual basis scrutinizes the Health and Wellbeing Board, so it has a good look and gives us constructive feedback. And to that purpose, we produce a report. The focus over this year, obviously, of the Health and Wellbeing Board was that it didn't just go about its normal business, but it took the main oversight role of COVID. So it had to shift and prioritize its usual agenda to fulfill that governance request. And for that purpose, the Health and Wellbeing Board set up a one-off, not a one-off, but a time-limited subgroup. It was called the Community Subgroup. It was particularly representative of our diverse communities. And the Community Subgroup met more frequently and really focused particular on the disproportionate impact of COVID on our ethnic communities, but also on our older people, the impact on young people, the impact on people with learning disabilities. The subgroup then focused very much on vaccination equity, and most recently on equity of access to long COVID services and increasingly therapeutics. So that's what the Health and Wellbeing Board mainly did. The second role that the Health and Wellbeing Board still managed to fulfill was in playing its part as a statutory committee in what we call the place governance. You mentioned that the NHS indeed has gone through preparing for the NHS reforms to create integrated care systems. And the Health and Wellbeing Board remains a statutory committee, so it had to engage to ensure that the governance makes sense at place level. So that was another focus of the board. And then finally, the Health and Wellbeing Board very much is playing a role in recovery. And particularly for Merton, that is the Merton 2030 ambition. And part of the contribution from the Health and Wellbeing Board is an approach of health in all policies that we have got some good foundations to build on. That's just a summary, and the details of all of that are in the report.
Thank you, Dagmar. Are there any questions? Okay, or can we agree the recommendations on page 47? Thank you. And that brings us on to item 7, which is topic suggestion requests for the municipal year 2022 to 23. Does anyone have any suggestions to make? As I understand it, there is suggestions made this evening will form part of a long list, which will then be considered by the panel created after the elections. So we're not able to, it wouldn't be right to tie the hands of our colleagues or future colleagues, but are there any suggestions for topics, or would you prefer to write in the warmth and comfort of your own homes and send an email into Stella to do that? Okay. Well, I've got a few that I can email you, Stella, so we will do that. So that concludes the business for this evening. Can I thank our colleagues from who have joined us remotely? At least you're warm, and thank you for answering our questions so thoroughly and presenting the report so comprehensively, and we're grateful for your assistance. I declare the meeting closed. Thank you.